Well, thank you for that kind welcome, and congratulations to you and the whole committee and Dr. Christian, and of course for putting on this wonderful symposium. And say congratulations and thank you to the audience for sticking through. I mean, it's late on a Saturday, it's sunny, it's New York, and you're still here. So you must be pretty dedicated to education. All right, so I'm going to, in the next 9 minutes, give a really quick update on renal denervation as far as the data and the randomized data. Hopefully my slide will advance. Okay, good. Here are disclosures relevant to this talk. In the past is some research funding from Medtronic, and I am currently working with a few companies on aldosterone synthase inhibitors and small interfering RNA as well. So the story for blood pressure, I think, is now much more simple than in the past. There's no question that increases in systolic and diastolic blood pressure are each independently associated with increasing cardiovascular risk. The higher the blood pressures, the worse the outcomes. And the targets of what is normal keep dropping, in fact, based on the data, and more recently the guidelines have reflected this. And it is likely the case that 130 over 80, or really even 120 over 80 is what is normal, that number and below. Now, within the universe of people that have high blood pressure, which is a pretty large universe, you saw some of the data from Dr. Szymanski, are those with resistant hypertension. There are lots of different ways of defining it, but the way I'm using it is just folks that despite being on 3 or more classes of medicines at whatever dose they can tolerate still have out-of-control blood pressure. And if we look at that, these are some data from the International REACH Registry, a large registry of patients with atherosclerosis. We see that those with resistant hypertension have much worse outcomes. And the worse the resistant hypertension, as proxied by having more medications on board, the outcome's even worse. So this is something I think that's intuitive, but gets to the point of why we want to treat these patients and control their blood pressure. And if the medicines aren't doing the trick, well, then we likely need something else. And perhaps then that something else is renal denervation. The story, at least in terms of a well-done sham-controlled randomized clinical trial, started with Simplicity Hypertension 3. And there, the design was randomizing patients with resistant hypertension to renal denervation or sham control, following them out up to about what ended up being about 4, in a few cases 5 years of follow-up. The primary endpoint at 6 months was not positive. There was a small reduction in blood pressure, but compared with the sham arm, it wasn't significant because both arms had a large and significant reduction in blood pressure compared with their baselines. However, if one looks at some of the secondary endpoints, things like nighttime blood pressure, there was a significant reduction even at the 6-month time point. If one looks at the subgroups, there were some subgroups as well where there was benefit of renal denervation, but a bit of a complex story to tell. Things like the African American patients not appearing to have a benefit, and the non-African American patients appearing to have about a 6 millimeter reduction in millimeters of mercury reduction in blood pressure. But that ended up having to do more with adherence. So it was a very complex story. So the top line message certainly was at that point that maybe renal artery denervation didn't work. But if we go back to Simplicity Hypertension 3 and look at the long-term data, then we see what might be the reality of what renal denervation does actually provide. And I'm not going to get into the statistical complexities of how this analysis was done because we had patients that were crossing over, not crossing over, some imputation. But the bottom line message is when one looks at the renal denervation arm with longer term follow-up versus a control, it did seem like there was a significant benefit in blood pressure. And if we look even at the very long follow-up here, where we no longer have a control arm, but had the observation of what occurred in the renal denervation arms, it looked like pretty large reductions in blood pressure, with the caveat that at this point the randomization is no longer preserved. That was office systolic, same pattern for office diastolic compared with the control arms. There did appear to be significant reductions in blood pressure, and that they seem to be durable, if, in fact, if anything, increasing with greater follow-up, not decreasing. The same was true for ambulatory blood pressure, both systolic and also diastolic. In terms of safety, there were really no safety issues to speak of. There have been concerns about, will this provoke renal artery stenosis or renal decline in terms of GFR, but none of that was observed. At the same time that the blood pressure control seemed better, there wasn't any change in the medication classes, so that can't be the explanation. That is, there weren't more medicines added on in the renal denervation arm that accounted for it. So it did seem to be the procedure itself. And in fact, the burden of medications, that is, if you look at not just the number of medicines, but the doses per day and so forth, was actually lower in the renal denervation arm. So despite this, there was better blood pressure control. If one looks at the 24-hour control as well, this is another way of looking at this. You can see over 24 hours significant reductions in blood pressure with renal denervation, where in the control arm that wasn't the case. And if you look at shifts in blood pressure, red being bad, green being good, in those that got denervation, you can see at 6 months and 36 months there's more green than there was initially. And in those patients that underwent crossover as well, at 6 months, there's more green and yellow and orange than here. So all these different analyses support that there, in fact, was an effect. Subsequent trials, in fact, with a more advanced generation of catheter, the spiral hypertension program, looked at patients off meds that had hypertension, perhaps the cleanest experiment, randomizing them to sham control and renal denervation and following them over time. And here, I think a very nice assessment that there was, in fact, a significant difference in blood pressure. So when you take out all the potential confounding that occurs for medications, adherence, are the patients really taking their meds? Is it differential adherence in the two treatment arms? Because the patients are, of course, always unblinded. They can always check their blood pressure at home. So it makes these trials very difficult to do. But here we see, I think, the truth that, for the strict randomized phase without any meds on board, somewhere between 4, 5, 6 millimeter reductions in blood pressure. And the same sort of patterns that I showed in the Simplicity trial were also seen here in terms of better 24-hour blood pressure control, sometimes called the always-on phenomenon. Unlike drugs, where for the most part, other than maybe RNAs and biologics, you have peaks and troughs depending on the dosing interval of the drug. So perhaps an advantage of denervation that doesn't rely on adherence, and it's always on, all 24 hours of the day. That is also followed with the spiral hypertension on-med design, where patients are also having hypertension but are on meds, in this case, a fixed regimen, randomization to the procedure or control, a follow-up for the intermediate term. And you can see here also that there are reductions in medication burden. In this case, also the number of antihypertensive medicines, rather small reduction, but still significant, both at 12 and 24 months, and for the most part, reductions in blood pressure at the various time points that are significant. Here, for example, in ambulatory blood pressure, the p-value wasn't quite significant, but interestingly, somewhat counterintuitively, the office systolic blood pressures were significantly lower. And if you look at the longer-term results from this trial as well, it does appear that there are significant reductions in blood pressure. And also the same phenomenon in the solid lines, the treated versus control in blue and gray respectively, and in the dashed line, the baselines. And you can see once more a good 24-hour control. Looking at the entire Simplicity program and examining what are the predictors that really say this patient's going to benefit or not. Dr. Sasemsky mentioned looking at biomarkers and other fancier things in the future, but right now nothing seems to predict benefit as much as having a higher baseline pressure. And that's quite intuitive, and that's what the data show. So really, I think renal denervation shines when the blood pressure is out of control, regardless of whether the patient's on all the meds you want them to be or not. So that was radiofrequency ablation. Let me switch now to ultrasound-based denervation. It's a very similar message, just a different technology. Two trials that I'll focus on here, Radiance Solo and Radiance Trio, looking at essential and resistant hypertension, randomization to sham procedure or an ultrasound-based denervation. And here, once more, the benefits are significant on blood pressure, whether it's ambulatory blood pressure or office. The p-values are significant. Similar sort of 6-ish millimeter of mercury reduction in the randomized sham-controlled phases of these trials. Similar sort of 24-hour control seen with renal denervation with this technology as with the other. Another Radiance ultrasound trial as well, again finding a similar degree of blood pressure reduction, the sort of 5, 6, 7 millimeter reduction in millimeters of mercury, and a 24-hour phenomenon as well, where blood pressure does seem to be controlled day and night. And if you pull the radiance data with ultrasound, a significant reduction in blood pressure. And if you adjust for the medication burden and changes in that, that amplifies the degree of benefit. And if you pull all the data together in terms of the radiofrequency ablation, including catheters I didn't discuss, such as the Iberis program and the NetRod program, and if you include the ultrasound denervation and the alcohol denervation as well, which for the sake of time I didn't discuss, but there's some positive data there as well, pulling all those different technologies, it seems like there is indeed a significant reduction in blood pressure, regardless of whether you're looking at office or ambulatory blood pressure, of a modest degree during the randomized phases of these trials, but with an amplification of that degree of blood pressure reduction that seems to happen once the trials go into more of an observational phase, perhaps reflecting what happens in real life. Thank you very much.